Laparoscopy, surgical, supracervical hysterectomy, for uterus 250 grams or less. With removal of tube, S, and/or ovary, S. Laparoscopy, surgical, supracervical hysterectomy, for uterus greater than 250 grams. With removal of tube, S, and/or ovary, S. The physician performs a laparoscopic hysterectomy, removing a uterus. After the insertion of a speculum in the vagina, the physician grasps the cervix with an instrument to manipulate the uterus during the surgery. A trocar is inserted periumbilically and the abdomen is insufflated with gas. Additional trocars are placed in the right and left lower quadrants. The uterus is dissected free from the bladder and surrounding tissue and its body is separated from the cervix. Coagulation is achieved with the aid of electrocautery instruments. Alternatively, some vessels may be ligated. The uterus is morcellized and removed using endoscopic tools. One or both ovaries and/or one or both fallopian tubes are removed in similar fashion. Once the excisions are complete, the abdominal cavity is deflated and instruments and trocars removed. The fascia and skin are closed with sutures. Laparoscopy, surgical, myomectomy, excision, 1 to 4 intramural myomas with total weight of 250 grams or less and/or removal of surface myomas. 5 or more intramural myomas and/or intramural myomas with total weight greater than 250 grams. The physician performs a laparoscopic myomectomy, removing 1 to 4 fibroid tumors from the wall of the uterus, intramural myomas, with a total weight of 250 gm or less and/or removes surface myomas. Electrocautery instruments and/or laser may be used to remove small surface myomas. Pedunculated myomas are removed by ligating, twisting, or snaring the stalk. The physician incises the uterus through the myometrium to expose the myoma, which is dissected free from the surrounding myometrium. The pedicle is isolated, clamped, and ligated and the myoma is dissected down to the pedicular blood supply. The adjacent myomas may be reached and removed by tunneling further through the initial incision. The uterine wall defects are sutured laparoscopic, the trocars are removed, and the wounds are closed. In 58,546, the physician incises the uterus through the myometrium to expose the myoma, which is dissected free from the surrounding myometrium. The pedicle is isolated, clamped, and ligated and the myoma is dissected to the pedicular blood supply. The adjacent myomas may be reached and removed by tunneling further through the initial incision. After resecting large intramural myomas, removing them from the abdominal cavity may require making a cooldotomy incision or using morcellation techniques. A mini laparotomy may be done with laparoscopic myomectomy as myomas are brought to the abdominal wall for removal and the uterus may be closed with some layered suturing. The laparoscopic instruments are removed and the wounds are closed. The laparoscope is placed through the umbilical port and additional trocars are placed into the abdominal cavity as needed. In the back approach, the trocar is placed at the back proximal to the retroperitoneal space superior to the kidney, adjacent to the adrenal gland. The physician uses the laparoscope fitted with a fiber optic camera and/or an operating tool to explore, biopsy, or removal of all or part of the adrenal gland. The abdomen is deflated, the trocars are removed and the incisions are closed with sutures.